So there's a number of different treatments that we can use to try and reduce the number of migraine that a patient who suffers gets. No medication will work in everyone. On average, any medication will reduce the amount of headache by half and the severity by half. And sometimes it can be a trial and error to find a treatment that works. And that can be very frustrating for people because they've been asked to try a treatment and then we ask them to build the dose up, take it for maybe 8 or 10 weeks at that maximum dose, and then they still don't have any benefit. And they've then got to try a second treatment. We can split, certainly in the UK, preventive treatments into two options, ones that GPs prescribe and ones that come from specialists. And we'll talk today about the GP treatments, and we can then cover the more specialist treatments in a second video. The three options that we have are a medicine called propranolol, which is a blood pressure tablet, and candesartan, a blood pressure tablet, and what are known as tricyclics. These are old-fashioned antidepressant tablets that really aren't used to treat depression now, but can help nerve pain and pain in general can be helped in headache. These medicines potentially have side effects, so they have to be started on a low dose, but built up quite quickly. Propranolol can sometimes cause a funny tummy and sleep disturbance. Candesartan occasionally, because a blood pressure tablet, people can feel a bit dizzy with it. And the tricyclics sometimes make people a bit sedated or dry mouth or a bit of constipation. But very often patients tolerate these treatments, and I've seen patients using these medicines in low doses actually getting significant benefit. I remember a colleague who had never had any preventive therapy, had propranolol just 20 milligrams a day and virtually stopped all her migraine. But we'll get patients who try higher doses and they don't work. So we'll maybe cover the next time what we can do for patients when these treatments don't work. Patients where these simple analgesics don't work, we then have what are called triptan medicines. The triptans are been around now since the 1990s, and these are migraine-specific treatments that help to put a migraine away. But triptans can be effective for many patients, but not for everyone. So the other treatment option we have is what's called rimegepant, which is available in the UK, and it's an acute treatment for migraine that works on one of the pain chemicals that is necessary for the process of migraine. It blocks a chemical called calcitonin gene-related peptide, or CGRP, which we understand is important in the pain pathway. And we'll pick up on CGRP treatments, I think, as well under preventive therapy. The final thing just to say is that opiates have no role at all in managing migraine. Any codeine-containing preparation potentially can cause headache. And as headache doctors, we try to avoid codeine in all patients. 7 triptans. You get some that are tablets, some that are melt in the mouth. There are 2 that comes as sprays, and there's 1 that's an injection. Now these are the options we have in the United Kingdom. Triptans can be quite effective if they're taken early during the migraine. But for patients who get aura symptoms, such as the funny vision or sensory symptoms such as pins and needles, triptans won't work for aura. They only work once headache starts. So we recommend patients start their triptan when the headache starts. Now, some of the triptans come as melt in the mouth preparations, and there's a common myth that those medicines are absorbed from the mouth through the lining of the gums. But in fact, the melt in the mouth triptans are just absorbed from the stomach. The reason they're melt in the mouth is so someone doesn't have to take a drink when they're taking their triptan. The of course is that some patients will vomit when they get a migraine, about 10%. It's important to ask if someone's an early or a late vomiter. So if you start vomiting in the first 30 minutes, hour of your migraine, a tablet's not going to work for you. But if you vomit later in your migraine, and you can maybe catch it before you start vomiting. There's 2 triptans that can become as sprays. The one we prefer is zomatriptan nasal because it's better nasally absorbed, although again, quite a lot of it's gastrically absorbed. For patients who vomit a lot and need something that's going to get into the system quite quickly, sumatriptan comes as an injection and we can use that. The problem with triptans, of course, is some patients get side effects, and they quite commonly make people sleepy. So sumatriptan can do that. They can make people a bit spaced out. They can sometimes give some chest pain or chest discomfort. So some patients will find that triptan can be effective at putting the migraine away, but they get side effects that are not tolerable. And those are the patients that we now have rimegepant, which is this small molecule blocker of this important pain chemical CGRP, and that's a tablet that can be taken. So for most patients, triptans can be helpful, but if they don't work or they're not tolerated or they're not allowed. So patients, for example, who've had cardiac events and strokes and very high blood pressure can't have a triptan, and we have the option of rimegepant for these patients. So we understand that there's this chemical, a protein called calcitonin gene-related peptide, CGRP, which is an important pain modulating chemical. And we think the pain from migraine comes from the structures around the brain. The brain itself has no pain fibers. So it's the lining of the brain, the blood vessels, the nerve endings. And CGRP plays an important part in that pain process. And if we block CGRP, that can help a number of people with migraine. And we can block it either with an injection that you take every month or a tablet that you take every day. And we'll give people the option about which of these treatments. They're generally well tolerated. They can sometimes cause constipation, maybe a little bit nausea, or sometimes a little bit of sleepiness. But for some people who've struggled with migraine for a long time, these targeted treatments have been specifically developed for migraine. Unlike the other options, which are a blood pressure tablet that might help headache, these targeted treatments can be very effective for some patients, and certainly for a lot of patients to have their life back and not have that disability. So we discussed treatments that primary care doctors, GPs in the UK can prescribe for migraine, but they won't work for everyone with migraine. And we now have some targeted treatments that can be helpful. And there's 3 different medicines we tend to use. One is Botox injections. There's a monthly injection of what's called monoclonal treatment, and then there's a tablet that can be taken daily. So Botox is licensed for chronic migraines, so that means patients who get headache at least half the month and half are migrainous. And what we do is we do 31 injections around the head every 12 weeks. And the idea of the injections is to dampen down that nerve input into the brain where your brain's overactive. Can we dampen that nerve put down? And we do 2 sets of injections 3 months apart, and 7 out of 10 people with chronic migraine will get a meaningful response by 6 months. And by meaningful, we mean a 30% reduction in headache frequency and severity. But Botox won't work for everyone, and there's some patients who have what we'll call high frequency episodic migraine, so they don't meet the Botox threshold of 15 days, but they might have 12 or 13 days. And what can we give for them?
And see, when you're talking about Botox, so obviously if you were to get Botox on your face and it was for aesthetics or something, it wears off after a amount of time. Is that the same if you get it for a migraine, or will the effects last for kind of longer?
So for most patients, it probably wears off, and we see that. So if people keep a headache diary for us, and they've had reasonable control, and in the last week or 2 before they're due the next Botox, their headache frequency is starting to ramp up again. So for some people, as soon as the Botox is wearing off, the headache starts to ramp up. There will be some people, though, that Botox is really effective, and when they stop it, they don't then go and ramp their headache frequency back up. But in my experience, most patients probably have to continue with Botox. And these are some of the patients we'll then offer them whether they want to have one of the targeted treatments.